Okay, hi students. We're going to do another lecture tonight. This one's going to be on skin cancer, so let me share the screen with you and we'll get busy talking about skin cancer. Let's see, screen share. Okay, now let's get the slideshow started from the beginning. Okay, here we are, skin cancer. This is a short slideshow, but it does a little bit of background on skin assessment and some other things that are beyond cancer. But I think it's got some great tools in it for you to use as you expand your nursing knowledge. The component on skin cancer that's about halfway through is what you're going to need to know for this test, but I do want to talk about general skin well-being. So you already know about skin, I understand. We need to talk about the three different major types of skin cancer, the symptoms and signs of them. And this ABCDE method is pretty important as far as a way of understanding skin cancer and identifying what moles have a possibility of being malignant. So the skin, you know, is for protection, controls our temperature, helps with fluid and electrolyte balance. It produces vitamin D through sun exposure. It's got an immunological function and eliminates stuff through sweat. And of course, it's directly involved in sensation and temperature control. So how do we assess the skin? Well, we look at it, we inspect, we palpate. We don't really percuss the skin. Percussion doesn't really have a role in skin assessment, and we don't auscultate the skin, but we inspect and we palpate. It says our ears, we do listen. We listen to what our patients complain about, and sometimes we hear snap, crackles, and pops in the terms of subcutaneous crepitus in our skin. We gather a lot, do a lot of history taking, data gathering. We get a database based on what our patients tell us their norms are. A Braden scale, as you know, is assessment of skin intactness and the risk for pressure sores, pressure ulcerations. And of course, nutrition is certainly important in the maintenance of good skin. So we're always going to start, anything we do, we start with the patient's health history, the patient's chief complaint. We find out about the subjective data that our patient gives us before we move into the objective data. And so health history is generally subjective, what the patient talks about. So I should go back. We want to know if they have work issues. We want to know when their skin problems started, what things they put on it. We want to know if they have family history of autoimmune disorder, genetic conditions, eczema, things like that might run in families. All kinds of things in the health history as far as sunburn and bites and bruising and scarring and tattooing and piercing and all those things that might influence our skin assessment. And then we're going to move through the points of physical examination. We're going to inspect, palpate, and that's the rest of the things pick up from here. So examining it, we always examine head to toe. We can do a systems assessment, but for skin, you know, as long as you're looking at the patient, you're starting with the face, the neck, arms, hands. So we're going to look head to toe. You want a well-lit area. You also want to have a pen light because sometimes you need oblique light to get a good assessment of the skin. You always compare one side to the other and skin in one area to other areas. So you want to see, are they cyanotic or not? Well, compare one to the other. Is it gray or ashen? Is it pale? How does it look compared to the skin of the rest of the body? Try and use standard words that are well known throughout healthcare. I know that back in level 1, you talked about words like macule and papule and petechiae and macule and wheal and urticaria and terms that define and describe lesions in the skin and the things that have happened with skin. Skin is a sensory organ, so certainly it affects sensory perception. You know, it's all things that you want to look at. Now, in the tool that is showing on the slide is the Braden scale. And so you know that the patient's ability to move, the patient's ability to, well, the ability of the skin to stay dry, the patient's ability to, you know, change their own position, the nutrition that they're eating, if they're laying in bed and having shearing force, all those things are considered in the Braden scale. But it's just one form of examination. You want to identify what variables are out there for your patient as far as, well, there's all kinds of variables out there for patient. Age, certainly, underlying disorders like diabetes that affect skin, give you yeast problems. And then when we document the skin, you want to be very specific. What did it appear like? What's the texture of the skin, the temperature? How's the turgor? You know, turgor is the ability of the skin to recoil back to its original shape when you pinch it up. And we generally use clavicular tissue, sternal tissue to measure that, not the backs of hands, because the older we get, the less collagen we have in hands. We look at color. We look at, is it warm and dry, moist, diaphoretic? Is there sensation okay? How's the vasculature? What's the capillary refill like? Do they have good color because of that? And then you go into specific lesions and rashes. And once you talk about the lesions on the skin, you have to talk about the size and where they're located and how they're distributed. To give you some example, here's some good assessments of the skin. Skin is pink, warm, dry, elastic, no petechiae, no lesions, no excoriation, multiple moles of small size, regular borders, regular surface. And I would like to say where those moles are, back of arms, neck, back. The other one, red macular rash, generalized over the trunk and thighs, confluent lesions measure up to 2 centimeters, abrupt onset. That's the patient's description, the abrupt onset, and then, or we might have seen it if we're in the room when it happened. So there's, in the notes for the slides, there's an additional couple of examples to give you some good assessments. I think it's important as a nurse, looking at stuff like this, it can help your charting. You can look at this and say, oh, there's some good words to use and ways to think about it, other than normal, skin is warm and dry. It's a little bit more than that. So let's talk about skin cancer. We have 3 major types of skin cancer we're going to talk about. We have basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. The front picture in this slide is just a normal cross-section of the skin. The picture that's looks like it's behind or to the left on this slide shows you where the squamous cells are, shows you on the epidermis where the squamous cells are, where the basal cells would be, and the melanocytes is where we usually see malignant melanoma, melanoma, tumor of the melanocyte. Okay, so here's pictures of the different kinds of cancers. The melanoma is the bottom picture. That is the worst of the 3 cancers, of the 3 types of skin cancer. Basal cell carcinoma has the best prognosis, is usually the least invasive, the slowest growing. Squamous cell is worse than basal cell. All of them can be bad if left alone long enough, but malignant melanoma is the one with the highest mortality rate. We have great success rates with basal cell, pretty good success rate with squamous cell. Malignant melanoma is pretty tough. So the risk factors for all of our skin cancers is excessive ultraviolet radiation, being out in the sun. So we want people to use sunblock. SPF 15 or higher is absolutely essential. We also want, if patients have had multiple sunburns, especially sunburns that have blistered, then that is a risk factor. People use tanning beds. Tanning beds have been shown. The first couple of years, I was like, well, there's no data. We don't know if they cause skin cancer. We have data now. They've been around long enough that we've discovered that tanning beds can indeed increase your risk of skin cancer. Malignant melanoma tends to run in families, so we do want that known if the patient has a family history of skin cancer. The lighter complexion a person has, the more susceptible to skin cancers they are. Darker complected skin, even though they have more melanocytes, aren't more at risk. And then any other medical conditions they have and medications they take that can make their skin more sensitive to the sun. Medical conditions, concurrent medical conditions that make them more susceptible to malignant changes in their tissues. So what we want to see, what we don't want to see with skin cancer is a new onset lesion that doesn't heal, it bleeds easily. If you've had a lesion over time, the shape and the color doesn't it changes. So it becomes irregular, the color changes, it gets darker. If the skin becomes lumpy or hard around that lesion and it was not previously, if the lesion is painful or tender or even itchy. So skin cancers, the A, B, C, D, E method are things we look at. Excuse me. Gonna drink. So A is asymmetry. Is it symmetrical or not? The mole it shows under asymmetry. If this was a perfectly round mole, it would be symmetrical. But you can see how there's a branch out from it. So if you took it and you divide it in half, any direction, the two halves would look very different. It's asymmetrical. The border is irregular. In the second picture of it says border irregularity. A mole that has intact borders, well-defined borders that are regular, is not a malignant mole generally. So if this one has an irregular border, then that's a bad sign, especially if it went from a regular bordered mole to an irregular bordered mole. The color, usually the darker the mole, we usually think of it as being worse, but black, purple, dark brown, gray, and if we have variation of colors in a mole or moles that have changed color over time, then they fit that criteria. The diameter 6 millimeters, we say 1/4 inch or the eraser end of a number 2 pencil. Anything bigger than that is a mole that is too big, especially if it's grown, if it has grown in size. So if it was smaller than a number 2 pencil eraser tip, then, and now it's bigger than that, then it's the D, it meets the D criteria. And E is evolution. The size, shape, and color has changed over time. So symmetry, asymmetrical, irregular borders, the color has variation, especially with the darker purples, browns, grays, and blacks. And it's greater, the diameter is greater than 1/4 inch, and the mole has evolved over time. And those are indications of malignant melanoma, particularly this skin cancer we're looking for with that. So what do we do if we suspect a mole is malignant? If you have a basal cell, quite often basal cell carcinomas happen on the cheeks, on the nose, the chin, places that get a lot of sun exposure. Squamous cell, basal cell and squamous both can happen on lips. I know we've talked with laryngeal cancer about cigarette smoking and alcohol having using them together can put the patient more at risk for that. In the case of skin cancers, especially on the lips, smoking and that heat source being repeatedly there can cause a squamous cell or a basal cell carcinoma on the lip. And you think about it, a heat source is a repetitive trauma to those tissues. And so I've seen patients with pretty significant squamous cell carcinoma on either side of their mouth where they would hold their cigarette when they smoke. So be thinking about that as a possible thing. So once we've identified there's some kind of mole or a lesion that needs to be investigated, we can do, remember we talked about incisional and excisional biopsies where we can cut into the tissue or we can completely remove the tissue. We can also do a punch biopsy where we take a coring needle and take a piece of tissue out of it. The shaving biopsies are a little bit different with skin, where we can just take layers of skin and shave layers of skin off. There's actually a procedure we can do that's diagnostic and treatment at the same time. It's called a Mohs surgery, M-O-H-S. We'll go in and we'll shave a couple layers off, send those tissues to the lab. They say, oh yeah, that's malignant, and the margins aren't clear with it. Shave a little deeper. They send another section to the lab. No, the cancer's still there. Margins aren't clear. Shave a little deeper. And now the margins are clear. That's called a Mohs surgery. And they'll do it outpatient, general or local anesthesia. And they do it over a series. It takes usually an hour or two because they have to take a piece, send it to lab. Lab has to get back to you, and they take another piece. But over the course of an hour or two, then they can complete down to where there's clear margins. They've shaved out enough. So shave biopsies, punch biopsies, excisional and incisional. Of course, labs and imaging. We want to find out if those lesions metastasize to other spots, especially if it's malignant melanoma. It's highly metastatic. And so we're looking at CBC, basal metabolic profiles, liver function tests, chest x-rays, PET scans. We can do lymph nodes near the malignant mole. And then, of course, staging is based on the size of the tissue, how deep in the tissue is, and whether it's metastasized or not. We talked about TNM, we talked about grading and staging in classification systems and other slide sets. So the treatment's going to depend on what kind of cancer it is, where it's located, how deep it is, and that patient's overall health history. If it's basal cell or squamous cell, the first thing we're going to do is just remove it. So excisional surgery, obviously the first thing we're going to do. Even malignant melanoma, we can go in and do it. We can go in and remove, unless it's widely metastatic, and then you can't get all of it. And then we'll treat it with chemotherapy. Radiation is not always the first choice for skin cancer. Radiation is a cause of skin cancer, and it doesn't always treat it. Chemotherapy is more often a treatment. The slide it's showing you here is a Mohs surgery. I love it, where it shows you a visible lesion. They take the first layer, the second layer, the third layer of skin. Anyway, if you didn't understand my Mohs surgery. So chemotherapy, it's going to be excision of the lesion, surgery to get as much of the tissue as we have to until we get clear borders, chemotherapy to follow. Even with malignant melanoma, that's going to be the course, and then we might have to come back later and get more and more and more tissue as the melanoma spreads. And malignant melanoma will set up and metastasize, and you'll get melanocytes that are malignant in the liver and on the spleen and on the pancreas and on the, on the brain and other places. So the squamous and basal cell are usually metastatic. If they're spreading out, they're just spreading out to tissues that they're near. But malignant melanoma does widespread metastasis throughout the body. So how do we prevent skin cancer? Limit sun exposure, put on sunblock, put on long sleeve shirts and a hat when you're going out in the sun. If you have to go out outside during hot months of the summer, try and go out in the morning and the evening. Hat with a brim always. And you should monthly assess your skin for moles and lesions to see if they're changing, so you know where your moles are and what they look like and if they're changing. And that's the end of the slideshow. Thank you. I will do another one shortly.